oncology and thoracic oncology. So we'll go with the first paper from head and neck. I welcome Dr. Padma. The moderator for the session is Dr. K.V. Sajeevan, HOD Medical Oncology. So please.
A very good morning to everyone. I'm Dr. Padma from the Department of Head and Neck Oncology. Today I'm going to present the first presentation on the ASCO updates. This presentation is on the immunochemotherapy as a single treatment modality for larynx preservation, assessing the co-primary endpoints and the safety results. This study was conducted by Dr. Renata Ferrarato et al. In the University of Texas MD Anderson Cancer Center. So, coming to the background of the study, for stage 2 and stage 3 laryngeal squamous cell carcinomas, the definitive treatment is a conservative laryngeal surgery or either the non-surgical management using radiotherapy or concurrent chemoradiotherapy. Both these strategies provide a 5-year locoregional control of around 85% and a maximum larynx preservation of around 70 to 85%. Even though they provide a better locoregional control and a larynx preservation, they are associated with significant morbidities such as 23% of patients presenting with severe dysphagia and 15% of gastrotomy tube insertion need and 30% of aspiration and around 10% people are tracheostomy dependent. An optimal treatment for larynx preservation for a laryngeal squamous cell carcinoma should maximize functional and oncological outcomes. So the rationale for the current study is based on a phase 2 clinical trial which showed that the chemotherapy regimen alone showed a durable remission of 33% of patients for a period of 5 years. All the patients treated in this phase 2 trial had only chemotherapy alone and they had their native speech and swallowing preserved. And the laryngeal preservation rate was around 83%. Followed by that, there was a phase 3 trial proving that adding immunotherapy to the chemotherapy regimen improved the overall survival in recurrent and metastatic head and neck squamous cell carcinomas. So, this study hypothesized that the addition of immunotherapy to the chemotherapy regimen would be well tolerated and have a significant activity in patients with stage 2 and 3 laryngeal squamous cell carcinomas. The regimen is pembrolizumab with cisplatin or carboplatin and docetaxel, and a proportion of these patients treated with immunochemotherapy would achieve a durable pathological complete response and the preserved function of the larynx. So, this is the trial schema of this study. All the patients who are in the stage 2 and stage 3 laryngeal squamous cell carcinomas who have given consent to participate in the trial have been included in the study, and these patients received 2 cycles of PCD, the pembrolizumab 200 mg, cisplatin 75 mg per meter square and docetaxel 75 mg per meter square. Following the 2 cycles of PCD, these patients were reassessed using the imaging, and during reassessment, these patients are based upon the RECIST 1.1 criteria. The image response has been assessed. If there is an image response in these patients again underwent subsequent 2 cycles of PCD, and followed by that, at the end of 4th cycle of PCD, these patients again were reassessed and a biopsy was done. And if the patients had a pathological complete response, these patients received again 4 cycles of a consolidation dose of pembrolizumab, and they were followed up from there. Those patients who showed a progressive disease and those patients who did not show a pathological complete response underwent a local definitive treatment using other modalities, either surgical or a non-surgical modality. The endpoints that are used to assess the outcome in this study is the two primary endpoints. That is, the first primary endpoint is the disease control rate following 2 cycles of PCD, and the second one is the pathological complete response at the end of 4 cycles. And the secondary endpoints are the safety and tolerability of PCD and 2-year laryngeal preservation rate, recurrence-free survival, and overall survival. And the most important is the functional outcomes are measured in the sense of patient-related outcomes using the following speech and swallowing indexes. That is MD Anderson dysphagia inventory, voice handicap index, and MD Anderson symptoms inventory. And the swallowing function was also assessed. And the exploratory endpoints of the study are the tissue and blood-based biomarkers. The sample size has been measured based upon the Bayesian optimal phase 2 design. Based upon this design, the null hypothesis was set at 65% of disease control rate and 15% of pathological complete response. And the null hypothesis is rejected if there are 19 of the 25 patients have disease control and at least more than 7 patients received a pathological complete response. So, the accrual period for the study is from August 2019 till December 2022. Almost 28 patients consented for the study, and of these 28 patients, only 24 patients were treated and 4 patients were excluded depending upon the screening failures. And among the 24 patients, only 23 patients were evaluable to assess the efficacy following the treatment protocol. Among the patient characteristics that have been included in this study, almost 58% of the patients belong to stage 3 and 41% of the patients belong to stage 2 category, and then 83% of the patients were in 0 stage and only 16% of the patients were node positive disease. Almost 45 patients received cisplatin alone and 54% of patients received carboplatin. And if there is any toxicity using cisplatin regimen, 4.2% of the patients were shifted to carboplatin, and almost 8% of the patients received less than 4 cycles of PCD and also less than 4 cycles of pembrolizumab. Coming to the assessment of the outcomes, the overall treatment-related adverse effects that occurred in at least more than 50% of the patients. This table shows the adverse effects that occurred in more than 15% of the patients. The most common adverse effect in descending order is 91% of the patients presented with fatigue and 79% presented with anemia and 45% of the patients presented with nausea. And there were only a limited number of patients with grade 3 or grade 4 treatment-related adverse events. Among the 24 patients, there were only 5 patients, that is 20% of the patients developed a serious treatment-related adverse effects, that is either grade 3 or grade 4, in that the most common being the grade 4 neutropenia. And all these adverse events were resolved following the treatment. The first primary endpoint is the disease control rate. Following the 2 cycles of PCD, the complete response was seen in around 52% of the patients, that is around 12 patients, and partial response in around 43% of the patients, and a stable disease in 4% of the patients. That is, the disease control rate was around 100% and none of the patients showed disease. The pathological complete response following 4 cycles of PCD showing 78% of pathological complete response. In these, the patients who have showed initially partial response following 2 cycles, among these patients, 7 patients showed complete response following the completion of 4 cycles of PCD, and there was 1 equivocal result in the complete response group. Assessing the recurrences after completion of the assessment of pathological complete response, 38%, that is 7 of the 18 patients showed recurrence and they were salvaged with local therapy according to the protocol, and almost 5 of these recurrences occurred within the 5 months and had abnormal appearance at the time of the biopsy. Those patients who hasn't received, who haven't have developed any recurrences, those patients who showed complete response received only immunochemotherapy, and rest of the other patients received other definitive treatment modalities. Those patients did not show a pathological complete response for a total of 4 patients, and they received either a surgical treatment or a non-surgical definitive treatment. And the recurrent patient, that is, and 7 patients who showed recurrence. Among these, only 1 patient needed a laryngectomy as a definitive treatment, and rest of the patients were treated using non-surgical modalities. Rest 11 patients were there who received only immunochemotherapy as a single treatment modality. Among these patients, only 1 patient required a local radiotherapy in order to treat a progressive high-grade dysplasia. Overall, 47% of the patients, that is 11 of the 23 patients, were treated with only the immunochemotherapy regimen without need for any radiotherapy or other chemotherapy regimens. These are the representative images. The first image showing supraglottic lesion and its post-treatment 3 months follow-up image. And the second lesion is also a 3 months follow-up image following the immunochemotherapy regimen. Coming to the assessment of the secondary endpoints, it is the larynx preservation rate, recurrence, and the survival. In this study, the median follow-up was around 20 months, that is a minimum of 4 months of follow-up and a maximum of 41 months of follow-up. The laryngeal preservation rate was around 91%. At the end of all the treatment modalities, among the 24 patients, only 2 patients required a total laryngectomy procedure, and all the other patients were managed without a laryngectomy, preserving the larynx. There is around 8% of recurrence rate in this study, and the survival was 95%, and only 1 mortality among the 24 patients. See, assessing the functional outcomes of these patients during the pre-treatment, during and the post-treatment period, the need for gastrotomy tube placement occurred in only around 20% of the patient during and post-treatment, and the need for tracheostomy during and post-treatment is around 12% of the patients, and in these 12% of the patient, 1 patient has been decannulated. But all these patients who required gastrotomy tube placement and tracheostomy tube placement are those patients who have been treated with other modalities also using radiotherapy. None of the patients who have been treated with the single modality immunochemotherapy were in need for a gastrotomy tube insertion or a tracheostomy tube insertion.
Yeah, was finishing. Yeah. This is conclusion. Okay, go ahead.
The study, the co-primary endpoints of this study is the disease control rate of 100% and a pathological complete response rate of 78%. And the 11 patients, that is 47 patients who were treated solely with a single modality immunochemotherapy, showed a PC therapy require a close long-term follow-up, and the functional outcomes analysis of this study is still ongoing. And none of the patients, as for now, has received a gastrotomy tube insertion or tracheostomy in patients who are treated with a single modality therapy. Thank you.
Thank you, Padma. Actually, the presenters who have to stick to time because it's okay. Well. This is a very important study, though it is a very limited study with a few number of patients and phase 2 study. But this is it's probably these sort of studies are going to change the conventional wisdom of treatment of laryngeal cancers, because you see that there is high amount of complete pathological responses to the tune of 77%, and none of the patients had progressed during treatment. Gastrostomy tube placement and tracheostomy tube is considerably less. Only 20% or something required a local therapy. But there are some major limitations for this study, of course. It's a very small study, need a long-term follow-up. We don't know what's going to happen to these patients. And But one good thing is that systemic relapse was very less. If at all it was relapse, it was all local regional. Only one patient had a lung mets or something. So very interesting study. Anyway, we need more studies like this. This is, I feel, something like last year we had this thing, dostarlimab for the rectal cancer. So this can be equated something like that. Organ preservation is the norm anyway. Thank you.
Thank you, Padma. Now we'll have the next from head and neck. Neoadjuvant nivolumab paclitaxel followed by response stratified chemoradiation in HPV negative head and neck squamous cell carcinoma. Dr. Megha will present the abstract, and I request Dr. Vijay Gopal, HOD Radiation Oncology, to moderate the session.
Good morning, I am Dr. Megha from the Department of Radiation Oncology. I will be presenting the trial, the DEPEND trial, which is a phase 2 trial investigating the role of neoadjuvant immunochemotherapy followed by response stratified chemoradiation in loco-regionally advanced HPV negative head and neck squamous cell carcinoma, which was a study conducted in the University of Chicago Cancer Center. The rationale for this study arises from the fact that historically survival rates for locally advanced HPV negative head and neck cancers have remained poor, with 5-year survival rates of only 50%, and current standard of care is associated with substantial acute and late treatment related toxicity. Therefore, it's a need of the hour that we improve treatment that improves survival along with reducing treatment related toxicity. Anti-PD-1 immune checkpoint inhibitors with or without chemotherapy has shown improved survival rates in both recurrent and metastatic settings. However, its role in the curative intent setting remains undefined. It's been shown that response following neoadjuvant chemotherapy is prognostic and may allow patient selection for radiotherapy de-escalation. Here, radiotherapy has been de-escalated in both dose as well as volumes to reduce both acute and late treatment-related toxicity. And sparing of elective nodal volumes may also be beneficial for the activity of anti-PD-1 therapy. This is a phase 2 trial which included 36 patients with one patient-related death due to tumor hemorrhage during the course of chemoimmunotherapy. Patients included were newly diagnosed, pathologically proven, treatment-naive, locally advanced head and neck squamous cell carcinoma which were HPV negative, stages 4A and 4B according to the AJCC 8th edition. Sites included were oral cavity, oropharynx, hypopharynx, nasopharynx, larynx and paranasal sinuses. And disease response was radiographic disease response assessment according to the RECIST version 1.1. They received 3 cycles of neoadjuvant chemoimmunotherapy which included nivolumab 360 mg day 1, carboplatin AUC 5 day 1 and paclitaxel of 100 mg per meter square on days 1, 8, 15. Following 3 cycles, they were radiographically reassessed and stratified according to their deep response rates, which was defined as 50% or greater response. Those who received more than 50% responses were put in the arm of response adapted chemoradiotherapy, wherein they received 66 grade to the gross tumor volume and the nodal disease along with margins. And for those achieving less than 50% response were put in the standard chemoradiation arm, where they received 70 to 75 grade to the GTV, the nodal disease and margins along with 45 to 50 grade to the elective nodal basins. And following chemoradiation, they received consolidation immunotherapy, nivolumab, 480 mg every 4 weeks for 9 cycles. The concurrent chemotherapy which was given along with the chemo-RT was cisplatin, 3 weekly schedule, 100 mg per meter square. They were both arms received conventional fractionation schedules as well as hyperfractionated schedules with agents paclitaxel, 5-FU and hydroxyurea. The baseline characteristics of the patient population was as follows. The median age was 58 years. with most patients being more than 20 years. All primary sites of head and neck were included in the study, and the disease characteristics were most patients were T4 stage primary, and nodal diseases most patients were belong to the N2 category. The immune checkpoint score was combined positive score, stratified as more than 1% and more than 20%. The response rate, the deep response rate was 54%, which met the statistical endpoint, and the objective response rates for the entire cohort was 89%. The response rate was also assessed according to the combined positivity score more than 1% and more than 20%. Those who belong to the category of more than CPS more than 1% showed deep response rates of 50. Of the 19 patients who received deep response rates, 15 of them had combined positive score of more than 1%, and those in the CPS more than 20, deep response rates were five of them had CPS more than 20. So what the slide shows is that those people in more than CPS more than 1 is predictive of achieving deep responses, and those who have more than 20, it's not very predictive of achieving a deep response. And what is meant by suboptimal responses? Less than 50% tumor shrinkage. So the median follow-up was 14 months, and they had predicted progression-free survival and overall survival estimates. The PFS was 64% and overall survival 76% for the entire patient cohort. Coming to the response stratified survival, response adapted chemo-RT PFS was 79% versus 46%, and overall survival for the response adaptive RT was 86% versus 67%. Both did not reach statistical significance. For the local regional control, response adaptive chemo-RT 85% versus 92%, and for distant control 100% versus 63%. Coming to the PDL1 expression scores, CPS more than 20, PFS was 83%, and overall survival also 83%. For the percentage, PFS was 57%, overall survival 73%. The safety and tolerability of the regimen, it was well tolerated and manageable toxicities with neoadjuvant, nivolumab, paclitaxel and carboplatin. One patient died during the regimen from tumor hemorrhage, that is disease progression. 69% of patients developed grade 1 to grade 2 peripheral neuropathy, which were managed with paclitaxel dose reductions, and 6% of patients developed neutropenia, which was managed with growth factor support and dose reductions. Almost all patients in the patient cohort developed grade 1 toxicities, but only 47 patients developed grade 3 to grade 5 toxicity, and the most common toxicity was gastrointestinal toxicity in the form of diarrhea. As said earlier, the grade 3 to grade 5 toxicities were more commonly reported in the standard chemo-RT arm as compared to the response-adaptive chemotherapy arm, which shows that this is a response-adaptive chemoradiotherapy reduces both acute treatment-related toxicity. This is a slide showing the divergent responses in two patients, where both had locally advanced squamous cell carcinoma of right vocal cord and supraglottis. Both received 3 cycles of neoadjuvant, following which one patient received 67% tumor shrinkage and the other person received 42% tumor shrinkage. Following chemoradiation, the follow-up showed that the patient who achieved more than 50% tumor shrinkage had no evidence of disease, while the patient who received less than 50% developed distant failure in the form of innumerable lung and bone metastasis. It is important to note that nobody failed loco-regionally in the nodal regions. No nodal failures were observed in the nodal regions which were omitted. So the conclusions to be drawn from the study is that neoadjuvant chemoimmunotherapy has led to deep response rates of 54%. Response-adaptive chemo-RT was associated with favorable survival and local regional control with reduction in radiotherapy volume and dose, along with a numerically lower rate of acute toxicity warranting further study. PDL1 and expression enriched for deep response to neoadjuvant chemoimmunotherapy in previously untreated HPV-negative locally advanced head and neck squamous cell carcinoma. However, late toxicity analysis and an additional biomarker analysis is needed.
It's a nice presentation. The good thing about this study is it's bringing back the neoadjuvant concept back into the locally advanced head and neck cancers. So far, most of the studies shown partial or negative results. So, with the advent of nivolumab and pembrolizumab, these studies are bringing back the interest and showing improvement in control of local region control of the head and neck cancers. Again, the neoadjuvant treatment response varies from across the subsection head and neck, from nasopharynx to larynx. So in this study, it has shown like a good response in oral cavity tumors also. So that means it's showing, it's giving a good prospect for the future. And one caveat about the study is it does not explore the role of surgery in non-responders or responders.
How is it different from the existing treatment?
Immunotherapy in the neoadjuvant setting so far. There was a phase 3 trial in
The conventional treatment is direct the radiation, concurrent chemo radiation. Come back to the concurrent chemo radiation, what was
from the chemoradiation point of view, they have reduced the dose as well as omitted elective nodal region. So patient will be spared from the late morbidity of the neck region. But the schedules followed were a little bit skewed. They have even given hyperfractionated schedules 1.5 gray BD along with paclitaxel. Their concurrent radiosensitizer was not to the standard of care. And sir, HPV negative is only important in oropharynx. They have stratified HPV negativity in all subsets, including nasopharynx also. So,
Thank you, mate. Thank you. So we'll go to the next abstract. This is from India. There was an abstract on triple metronomic therapy in head and neck squamous cell carcinoma. Dr. Vishnu will present the abstract. I request Dr. Sridharan sir, Senior Consultant Medical Oncology, to moderate the session.
Going straight from immunotherapy to metronome.
Good morning, everybody. I'm Dr. Vishnu from the Department of Medical Oncology. So, I'm presenting this study reported from India and presented by Dr. Rishabh Kothari from Ahmedabad. So, this was a phase 3 randomized study for evaluation of physician's choice treatment versus triple oral metronomic therapy as second-line therapy in head and neck cancer. So the background of the study is that more than 80 to 85% of head and neck cancer patients in India are reported in diagnosed in a locally advanced stage, which either fail or relapse. And options for patients who fail within the first 6 months of initial therapy or people who progress, I mean, the options for further systemic therapy remains limited. And the outcomes with chemotherapy in second line or beyond remains dismal, with median OS of 4 to 6 months and 1 year OS of 16 to 26%. And people who are immunotherapy naive have an option of nivolumab and pembrolizumab, with Checkmate 141 trial reporting a median OS of 7.5 months and a 1 year OS of 36%, and Keynote 040 reporting a median OS of 8.4 months and 1 year OS of 37%. However, in resource-limited conditions like ours, the access to immunotherapy remains less than 3%. Oral metronomic therapy remains an option for palliative systemic therapy in low and medium income countries like ours, with median OS of 7.5 months in first line and a 1 year OS of 24%. And triple oral metronomic therapy has shown a response rate of almost 50% and a median OS of 6.57 months in first and second line, with a 1 year OS of 16%. And the advantages of triple metronomic therapy is that it's oral, less financial toxicity, improves the quality of life, and less incidence of significant adverse effects. So this was a phase 3 open label randomized superiority study. The inclusion criteria were adults more than 18 years of age with head and neck squamous cell carcinomas which are platinum refractory or those receiving second line therapy and beyond with a good performance status of ECOG 0 to 2. So they were randomized 1:1 proportion to oral metronomic therapy with oral methotrexate 9 mg per meter square weekly, erlotinib 150 mg OD and celecoxib 200 mg BD versus a physician's choice of treatment among the NCCN recommended options. And the primary endpoint of the study was overall survival, and secondary endpoints were progression-free survival, quality of life, and adverse effects. So these were the second line options used as physician's choice: taxanes, immunotherapy, nivolumab and pembrolizumab, afatinib, cetuximab, and other agents like gemcitabine. The sample size was 114, and total 120 patients were assessed for eligibility, and 114 of them went on to get randomized, and 55 of them were allocated to the metronomic arm and 59 to the physician's choice arm. And ultimately 54 out of the 55 in metronomic arm went on to receive the allocated treatment, and 54 out of 59 in the physician's choice arm got the treatment. And 13 out of the 55 continued the treatment in oral metronomic, whereas 42 had to discontinue treatment. In the physician's choice, 6 went on to continue the allocated treatment, and 53 had to discontinue. In both the arms, the common reasons for discontinuation were progression followed by death. And 55 went on to undergo intention treatment analysis and per protocol analysis, 54 out of the 55. And whereas in the physician's choice arm, 54 out of the 59 received a per protocol analysis. Coming to the baseline characteristics, both the age of around 46 to 50 among both the arms, and elderly patients constituting around 7 to 8%. Almost 50% of the patients were males and 8 to 9% in females. And performance status of 2, around 9 to 10% in both the arms. And the most common site of the primary cancer was oral cavity, constituting around 90% in both, 80 to 90% in both the arms. The primary treatment received was around 90% cases it was platinum, and 50% patients received taxanes. And the indications for the change of therapy was most commonly local region recurrence, around 70% in the metronomic arm and 60% in the physician's choice arm, and around 30% developed metastasis, whereas around 40% developed metastasis in the physician's arm. Coming to the overall survival, in the metronomic arm it was found to be 181 days with a hazard ratio of 0.5, and it was 123 days in the physician's choice arm. The progression-free survival was again 120 days in the metronomic arm versus 70 days in the physician's choice arm with a hazard ratio of 0.49. Coming to the adverse effects, almost all major side effects were significantly higher in the physician's choice arm, with neutropenia and thrombocytopenia of all grades, and severe anemia, transaminitis, and renal toxicity being higher in the physician's choice arm. Similarly, rash and diarrhea and neuropathy were also, of all grades, were also significantly higher in the physician's choice arm. And among the chemotherapy received among the physician's choice arm, most commonly was paclitaxel, followed by afatinib and docetaxel. The median number of cycles received were 4 in both the arms, and the most common reason for stopping was progression followed by death in both the arms. So to conclude, metronomic chemotherapy has significantly improved the outcomes in terms of overall survival and progression-free survival in platinum refractory and second-line therapy in head and neck cancers, and it has significantly lesser incidence of adverse effects compared to the physician's choice of treatment. Thank you.
nothing much to discuss in this slide. We have gone through this when the GMH team came here. Just a couple of points. One is, just like in immunotherapy, we need a good biomarker. All of us have metanomic patients with diffuse large B cells, with ovary, with breast, doing very well. So, but there will be a very small percentage. We need to find out who is the person who is going to respond well to metonomic therapy. That is one. Second is, just because it's metonomic therapy, I don't think anybody should think that it is non-toxic. It has significant side effects, especially when you're using a TK and silicoside. Just one more point. Vishnu, can you go back to that few slides? Few more. Yeah. Yes. No. No. Next slide. Previous one. No, the next slide. No. The one before.
So,
The one before. This one. Majority of the patients had local recurrence after radiotherapy. Why were they not taken up for salvage with surgery instead of giving a second line chemo? I think that's the major criticism for this trial. Because you see that 70% of the patients received radiation as first line, surgery was not offered. Any discussion on that? No.
He was told as, I think so that they told they were unfit for surgery or not willing for surgery.
PS 0 to 1.
No, that means they were not willing or what? That was the reason they told.
Thank you, Vishnu. So next we'll go to radiotherapy paper. It's a tumor treating field versus standard of care following a platinum failure in head and neck cancer. I welcome Dr. Arya to present in lung cancer, and I request Dr. Samir, Senior Consultant Radiation Oncology, to moderate the session. There is some glitch in loading the abstract, so we'll go for the next abstract and we'll load this later. I request here Dr. Altaf to present this abstract: chemotherapy versus chemotherapy plus pembrolizumab in pleural mesothelioma. And I request Dr. Dilip Balatol to moderate the session, consultant medical oncology.
Good morning all. I'll be talking about INC 227. It is a randomized phase 3 trial done by collaboration of Canadian Cancer Trial Group, National Cancer Institute of Naples, Italy, and French Intergroup Thoracic Group. It compared chemotherapy versus chemotherapy plus pembrolizumab in treatment-naive pleural mesothelioma. The thing is, majority of pleural mesothelioma comes to us with advanced incurable disease, and since 2003, the standard of care was platinum pemetrexed combination based on a phase 3 trial by Vogelsang et al. And it has reported a median overall survival of 13 to 14 months. Then in 2021, Bass et al. Did a phase 3 trial which reported improved overall survival when giving immunotherapy, nivolumab and ipilimumab. And the rationale for this study is single agent pembrolizumab is active in treating previously treated mesothelioma, which was shown in Keynote 028. It was a phase 1b trial done with 28 patients, which showed improved overall survival up to 18 months. And CP plus pembrolizumab is well tolerated regime in non-small cell lung cancer. That has also been shown in studies. There was a phase 2 study which showed improved survival up to 17 months when adding pembrolizumab with CP. Then they started phase 3 trial. In phase 3 trial, chemotherapy naive patients with pleural mesothelioma was included. Number of patients was 440, which was stratified based on histology, epithelioid and non-epithelioid, and randomized into platinum, cisplatin, pemetrexed group, and addition of pembrolizumab. The primary endpoint was overall survival, and they looked at PFS, response rate, and tolerability as secondary endpoints. All the patients after the phase 2 interim analysis was taken for this study, and 440 patients were included. These are the eligibility criteria: good performance score, adequate hematological liver and renal function, and the disease should be measurable by mRECIST to look at the response rate. This is the disposition. 440 patients were randomized, 218 in the CP group and 222 patients in the pembrolizumab group. All baseline characteristics were properly matched. Majority were males as expected, and then asbestos exposure. As you can see, majority patients had asbestos exposure. Major histology was epithelioid histology, and PDL1 more than one was PDL1 positive was also majority, 60%. And in pembrolizumab arm, 16% had discontinuation due to adverse events, and 13 to 14% had to convert from cisplatin to carboplatin due to adverse events. This is the overall survival Kaplan-Meier chart showing a 6% increase in 2-year OS and 8% increase in 3-year OS. Median survival is 16% in chemotherapy arm, 16 months in chemotherapy arm, and 17 months in pembrolizumab arm. This is a forest plot showing the PDL1 negative, age more than 65, then non-epithelial histology and poor prognosis score with URTC had better impact on the study. This is a Kaplan-Meier showing PFS. PFS was not that statistically significant different. But in subgroup analysis, the non-epithelial histology and male gender and age more than 65 had significance. And when they assessed best overall response on adding pembrolizumab, 1% had complete response and 60% had partial response compared to chemo alone arm which had 38% only, and significant p-values there. And disease progression was not statistically significant. And adverse events, both sides had significant adverse effects, especially on adding pembrolizumab up to 16%. And diarrhea, pruritus, maculopapular rash and febrile neutropenia are the most common ones. The conclusion is addition of pembrolizumab to standard platinum pemetrexed combination in untreated pleural mesothelioma demonstrated statistically and clinically significant improvement in overall survival. 21% reduction in risk of death with improved 3-year survival from 17 to 25%. And PFS, there is a 20% reduction in risk of progression or death. An overall response rate up to 60% overall response rate was there when adding pembrolizumab compared to chemo alone. The combination was tolerable and the side effects were comparable in both arms. So platinum pemetrexed along with pembrolizumab is a new therapeutic option in the treatment naive pleural mesothelioma population. So this is a testimony from one of the treated patients. The patient was enrolled in the 227 trial and she is in remission. Thank you.
Thank you, Dr. Altaf. This basically was a trial conducted in 3 countries, Canada, Italy and France. It was a phase 3 trial based on the results of an initial phase 2 trial of the same in 227, which had 3 arms actually. Initially it had 3 arms of pembro plus chemo, pembro and chemo. But the pembro arm was actually withdrawn because of the interim analysis which showed disease control which was not significant. So the phase 3 trial they only included the 2 arms. So as Altaf presented, the baseline characteristics were matched in both the arms, and the OS and PFS actually were significant statistically, but it was just a single month difference between both arms. And it was also as per the non-epithelioid mesothelioma had better response rates and survival, as based on the initial study of checkmate 643 of nivolumab plus ipilimumab, that's dual immunotherapy, which was tried initially. The first trial of immunotherapy came as a checkmate 643 for the nivolumab plus ipilimumab as compared to the chemotherapy. In that also the non-epithelioid actually had better survival benefit. All in all, if you see if it's a practice changing or not, I don't think it's a practice changing yet. So we need to have more phase 3 trials. I think there are 2 more trials which are ongoing in the same lines, and the results of that have to be seen to see if it can be brought into our clinical practice. But it's an interesting study, and there's a need to identify better biomarkers also to identify which patients will benefit more from addition of immunotherapy compared to chemotherapy. This is my take on this.
Thank you. What is the percentage of improvement in the easier to treat population this compared to the chemotherapy alone?
Only 1 month, sir.
Thank you.
Thank you.
Next, I request Dr. Arya to present on tumor treating field. Dr. Samir, Senior Consultant Radiation Oncology, will moderate the session.
So, good morning everybody. I am Dr. Arya Surendran from the Department of Radiation Oncology. So, today we are going to say about a phase 3 prospective randomized control study for the use of tumor treating fields therapy with standard of care versus standard of care alone in metastatic non-small cell lung cancer. So, it is the LUNA study. So, before going into the study, a few words about the tumor treating fields. The tumor treating field is a non-invasive regional anti-mitotic treatment modality using low intensity and intermediate frequency alternating current and administrating it via the use of electrodes, which are insulated electrodes, for a chronic period of time. So this was a multi-centric study involving around 17 countries and in Europe, Asia and US. So basically, metastatic non-small cell lung cancer remains incurable despite the introduction of many new and effective therapies. So the population under this study was the patients who initially had received a curative therapy or a palliative therapy in the form of platinum-based regimens and have progressed, and they are being enrolled into this study. So here already we have the phase 3 keynote checkmate trials etc., which was proving the effectivity of the immunotherapy and against docetaxel. So here in this study we are using this, that is the patient coming after platinum failure and he is not being started on any other agent. So he can be decided by the physician whether to start on docetaxel or any immune checkpoint inhibitors. Immune checkpoint inhibitors may be pembrolizumab, atezolizumab or nivolumab. Along with that standard of care therapy, he is given TT fields therapy also. So that forms our control arm, study arm, and the control arm remains the standard of care whichever is being there. So this tumor treating field therapy, as I mentioned, are low frequency, low intensity, intermediate frequency waves. So basically they does not have a tumor ablating effect. So it is found to have this on the cell. We know they will be having a negative charge in the cell. So it is tend to cause a polarization in the cell, and it affects the mitotic spindle formation, and also it can also disrupt the constituents of the cell by dielectrophoretic dislocation of the intracellular components. So that is basically the mechanism of action in this. So here we are asking the patient to wear a medical device with 2 pairs of arrays with adhesive bandages, and it is being allowed to wear during the entire course of the study. So this has been approved in the case of glioblastoma and malignant pleural mesothelioma. So it is a pilot study which demonstrated the safety and feasibility in advanced non-small cell lung cancer. So as I mentioned, so the company will sponsor. Here in the study they used Novo TT field, that device name, and they will be in contact with the technician, and anytime any problems they can contact them. And so as I mentioned, the mechanism, these fields either they cause cellular stress or they disrupt the mitosis, that is mitotic spindle formation, and hence leading to cell death. So in this study, so the eligibility criteria were more than 22 years of age, metastatic case, and all primary case which having progression after platinum based therapy, ECOG PS 0 to 2. So total 276 patients were enrolled and they were divided into 2 arms. So depending on the investigator's choice, the standard of care can be immunotherapy or docetaxel, and they were followed up every 6th weekly using CT scan until progression, and after progression 3 follow-up visits were there and until survival. So the primary endpoints were that overall survival using TT fields and standard of care versus standard of care alone. And the secondary endpoint was basically comparison, that is overall survival in the immunocheckpoint treated subgroup, in the docetaxel subgroup, and additional secondary endpoints were the progression-free survival, overall response rate, and progression survival compared with the histology, and safety of this modality. So the baseline demographic characteristics were almost similar. So as we can see, there were total 137 in the study arm. That was 63 patients going with 64 patients with immune checkpoint inhibitors and 63 with docetaxel, and the other standard of care also similar population, and majority were males, and race, ethnicity, everything was similar in both groups, and smoking history was also almost similar. And the disease characteristic also we could see, we are non-small cell, so non-squamous or squamous, that was non-squamous were around 58%, whereas squamous 42 to 46%. It was also comparable in both arms. And another point was, initially in this study, patient with brain metastasis were excluded, but later those who have treated brain mets and stable disease, stable brain mets were also enrolled in the study. So now the treatment exposure, that is how long did the patient use the device. So in both arms the range was almost similar, that is around 14.6 months versus 12.7 months. Median range of exposure was around 6 weeks, 14.6 weeks. So the therapy duration in TT field was around twofold greater in the ICI versus the docetaxel subgroup. So when they came after the follow-up, initially the study was started in September 2016, and it was supposed to be end in September 2023. So in their update in June 2023, so they found out that there was a significant difference in the overall survival in the study arm. That is, there were around 13.2 months of median overall survival in the TT field arm versus 9.9 months in the control arm, and the p-value was 0.035, which was a significant result. And similarly, so comparing the immuno checkpoint inhibitor arm and this thing also.
immunotherapy combination and immunochemotherapy alone. Safety profile assessed were immune-related adverse event as well as discontinuation rate due to adverse event and treatment-related death. Coming to the patient characteristic, the median age of the population was 78, majority of the patients were male, and majority of them had a ECOG performance status of 1. The majority were current or former smokers with a histology of adenocarcinoma, and the disease stage was mostly stage 4A, and the PD-L1 tumor proportion score, most of the patients were having a score of more than 50%. And the regimen, 34% received immunotherapy alone, and 28% received immunotherapy plus chemotherapy combination. Coming to the result, when they analyzed the PFS between the different groups, it was found that there was no significant difference in PFS between the immunochemotherapy and the immunotherapy arm. Similarly, coming to the OS was nearly the same between the immunochemotherapy arm and the immunotherapy arm. But there was significant difference in OS between the chemo alone group. So coming to the propensity score matched PFS and OS difference between the different group. This is a group of PD-L1 more than or equal to 1%. When propensity score matched, there is no significant difference in PFS and OS between the immunochemotherapy group and the immunotherapy alone group. Similarly, in the PD-L1 1 to 49% group as well as in the PD-L1 more than 50% group, there is no significant difference between the immunochemotherapy as well as the immunotherapy arm. Coming to the safety profile, immunotherapy related adverse events of grade 3 or more was seen in 24.3% of the patient with immunochemotherapy and 17.9% of patients with immunotherapy alone. And among this, pneumonitis is the most common, which was seen in 23.4% patient of the combination group and 15.6% of the patients of immunotherapy group. And steroid use for immunotherapy related adverse event was required in 32% patient in the combination group and 24% patient in the immunotherapy alone group. Treatment discontinuation was required in 26% in the combination group and 24% in the immunotherapy alone group. So what's the conclusion from this? In real world data from patients aged 75 years or older, the combination of immunotherapy plus chemotherapy did not improve survival compared to immunotherapy alone, but increased the incidence of grade 3 or higher immune related adverse event. So from this data, we can conclude that ICI alone, that is immune checkpoint inhibitor alone, is a good strategy for elderly patients with PD-L1 positive advanced non-small cell lung cancer. The combination of chemotherapy increases the toxicity with no significant OS benefit.
Thank you, Dr. Neeraja, for the presentation. We have an unmet need in the age group between above 75 years. Advanced non-small cell lung cancer, where because this patient group is least represented in many of the clinical trials, especially the immunotherapy trials. In the major trials, they have a representation less than 10%. So we don't know whether the immunotherapy will work for them or whether they have higher adverse events. So there were several attempts to study, all of them were retrospective. This also is a retrospective study, and unless we have a proper trial, we will not be able to identify whether these patients are going to be benefited by treating them with the immunotherapy. At the moment, looking at this trial results, it seems that the patients are going to be benefited if they have a score of more than 1%, and even single agent immunotherapy is sufficient, and there is no added advantage of adding chemotherapy along with immunotherapy for treating such age group. So this is a practice changing, basically looking at whether to combine chemotherapy along with the immunotherapy in this age group. The trial says the benefit is negligible, and they can be treated very well with the single agent immunotherapy. So the take-home message is elderly, above 75 years, we can very well offer them immunotherapy provided the PD-L1 score is more than 1%.
If score is not 1%, there is no point in using.
There is no point in using, but the trial included about 15% of the patients. but they are all retrospective studies, and there is no prospective study to clearly demonstrate the benefit. And when you are adding chemotherapy, there will be more toxicities.
Thank you, sir. So we'll go to the last abstract from thoracic oncology. Nivolumab has been approved for neoadjuvant in lung cancer. So this is the surgical outcome of patients with resectable NSCLC receiving neoadjuvant immunotherapy with nivolumab plus relatlimab or single agent nivolumab. And to present, I request Dr. Chandrasekhar to present, and I request to moderate Dr. Shyam Vikram, HOD Surgical Oncology, to moderate the session.
So, surgical outcomes of patients with resectable non-small cell lung cancer receiving neoadjuvant immunotherapy with nivolumab plus relatlimab or a single agent immunotherapy. This was conducted
Scroll down.
conducted at collaboration of West German Cancer Center, Jesse Hospital, Belgium, and Netherlands Cancer Institute, Amsterdam. So, background of the study was feasibility and safety of neoadjuvant perioperative immunotherapy with PD-1 immune inhibitors, PD-L1 inhibitors, and CTLA-4 inhibitors has been established. Novel agents beyond established PD-1, PD-L1, and CTLA-4 inhibitors and predictive biomarkers in addition to the PD-L1 are needed. Preoperative immune checkpoint inhibitors provides a window for early response assessment and correlative biomarker research on novel agents and combinations with sufficiently established clinical safety profile. This is the first experience with relatlimab, nivolumab in resectable non-small cell lung cancers. So study design was randomized control phase 2 study in patients with resectable non-small cell lung cancer to explore the feasibility, safety and efficacy of the combined preoperative treatment with nivolumab and relatlimab, a monoclonal antibody targeting lymphocyte activation gene 3. Reference arm was with single agent, that is nivolumab monotherapy. The primary study endpoint was feasibility of the curatively intended surgery within 43 days of completion of the immunotherapy, and secondary endpoints which were studied as radiological and histopathological response rates and disease-free survival and overall survival at 12 months, and safety of the regime and arterial resection rates. Study design. Patients were randomized into two arms, Arm A and Arm B, each arm containing 30 patients. Arm A patients received nivolumab alone, and Arm B patients received nivolumab along with relatlimab, that is nivolumab 240 mg and relatlimab 80 mg at 2 weekly duration, that is day 1 and day 15, and were assessed for the feasibility of the surgery within 43 days and standard of care adjuvant therapy later. Patient characteristics, like number of male and female patients were 1:1 ratio, like 29 out of 60 patients were females. Median age in the arm A was 65 years and arm B is 67. Histologically, most of the cases were adenocarcinoma and squamous cell carcinomas, and UICC stage in the both arms were comparable. And PDL1 status, tumor proportion score was used, and both arms have comparable scores, PDL1 status. Central tumor location was seen in 50% of the patients in arm A, that is monotherapy, and 45% of the patients in arm B. And R0 resection was achieved in 57 patients out of 60 patients. And unexpected pleural calcinosis was found at the surgery in 2 patients, and out of 95% received curative resection. Type of surgery was lobectomy in most of the patients, and bilobectomy in 2% in arm A and 1 in arm B. Sleeve lobectomy was required in 5 patients and received nivolumab alone, and 4 patients who received limonlimab and relatlimab, and lobectomy with segmentectomy was done only in single case in arm B. Approach for the surgery was mostly it was video assisted thoracoscopic surgery in 60% of the patients in arm A and 63 in arm B, and thoracotomy in 40% of the patients in arm A and 36% in arm B. Conversion was required in 3 cases who received monotherapy and 2 cases who received double agent therapy. Mean operating time was 149 minutes, that is almost 2.5 hours in patients who have received single agent therapy, and 165 minutes, 15 minutes extra compared to the previous one. And resected lymph nodes were comparable, like 15 in the single agent and 10 in double agent. And perioperative complication rates were 33% in single agent arm A and 26% in double agent. Average drainage duration of the ICD tube was 4 days in single agent and 3 days in double agent. And average hospital stay was 7 days when we used single agent, and it was 5.5 days in when we used double agent. Perioperative complications. So conversion, one conversion was due to bleeding, that is intraoperative conversion from VATS to open surgery, and 2 cases needed revision surgery. One was because of empyema and other one was prolonged ear leak. And in case of patients receiving double agent, only one was similar data, that is one case got converted to open case due to bleeding, and one case needed revision surgery because of middle lobe torsion. Immunotherapy treatment related adverse effects were anemia, atrial fibrillation, hypothyroidism, gastrointestinal bleeding, and hepatic dysfunction, proteinuria. All were comparable in both the arms. Coming to the histopathological response, so protocol definition of viable tumor cells was like 0 to 10% was considered as major pathological response, 11 to 50% was considered as pathological response, and biopsy report with the viable tumor cells of 51 to 100% was considered as no pathological response. When we compare both the nivolumab and nivolumab with relatlimab, pathological complete response was seen in 30% when we used nivolumab alone, and when 16% when we used nivolumab along with relatlimab. Major pathological response was seen in 27% when we use single agent and 30% when we use double agent. This is the radiological and metabolic response in a case where we can see the screening CT, like when after nivolumab with relatlimab showing a partial response. Like preoperatively it was CT3 N0 M0, and post-operative stage was T1A N0 M0, and pathological response was having 30% of viable tumor cells. Compared to the single agent, that is only nivolumab alone, when the preoperative stage was CT3 CN0 and M0, after the 2 cycles of the neoadjuvant immunotherapy, there was progressive disease, and the pathological post-operative stage was YPT3 N0 M0 only. So it also contained 80% of viable tumor cells. Coming to perioperative outcome and follow-up, perioperative like 30-day mortality was not seen in both arms. Adjuvant therapy was started normally in both arms, and 12-month overall survival and disease-free survival was 96%. 12-month survival was 96% in both arms, and disease-free survival was 91% in both arms. So the conclusion is minimal invasive and open techniques, both the surgeries can be conducted safely in a patients who are receiving single agent neoadjuvant immunotherapy or double agent neoadjuvant therapy. There seems to be no increased risk of complications in bronchial or vascular sleeve resections, and perioperative course morbidity mortality rates are comparable in both the arms. Protocol has been amended to explore the higher dose of relatlimab for increased LAG3 target occupancy. Currently, they are using 80 mg on day 1 and day 15, that is 2-week duration.
Now, I think the neoadjuvant treatment has become a standard of treatment in all the solid cancers. And now I think immunotherapy is taking a big role, at least in combination with chemotherapy or alone. It's good that the tumor response rate is good in combination immunotherapy. From the surgeon's point of view, the life is a bit tough after immunotherapy, because we have operated 1 or 2 cases of lung after immunotherapy. There is fibrosis and loss of fat plane with the adjacent structures is very big. At least for a beginner who is practicing in thoracic oncology, it will be a tough time after immunotherapy. That's what from a surgical point of view.
There is a very high pathological CR rate in the population. So probably we need to see whether this will be translated into our also. Again, there was some skepticism for breast also when it was started, that whether the pathological CR will be translated into the good PFS and OS. But ultimately it was proved that it matters. So if you extrapolate the same results in the lung, probably yes.
Yeah. Wasn't there any interstitial lung disease and all related to immuno?
Relatlimab is new for those who are not aware. It's a new LAG3 inhibitor. It's a monoclonal antibody called lymphocyte activated gene 3. So until now we were dealing about PD1 and PDL1 inhibitors. Now we are going for CTLA4, this ipilimumab. Now this is a new class called LAG3 inhibitors. So it's already approved in melanoma in combination with nivolumab in adult and pediatric melanomas. So LAG3 inhibitors is also by Bristol Myers is developing the drug. So they are combining it with nivolumab and has shown to increase the efficacy. If there is no more point, I think so. I thank each and every one of you for participation. The take home from this week was basically head and neck and thoracic is going for an immune wave. We have seen different papers telling that chemotherapy can be safely omitted. and by 2026, majority of the generic immunotherapy will come to Indian market. So it will be very difficult for even not only a surgeon, for a medical oncologist also to decide that whom should receive or whom not to receive. So thank you one and all. Next week we'll join again. We'll share the agenda about next week, Wednesday morning 8:30. Thank you.